So who are the people who are more prone to arthritis, and what can you do? Well, what we found is that people with chronic diseases like diabetes, those with other endocrine problems, can be more prone to arthritic knees. Also, there are certain inflammatory diseases like rheumatoid arthritis as well as ankylosing spondylitis, which can make you prone to arthritic changes at a much younger age. People who suffer with arthritis at an older age are those who suffer from what is called as osteoarthritis. What essentially happens is that in younger people, if you have slight damage to your cartilage, then the wear and repair match each other. But as you grow older, the tendency for repair goes down, and which is where you tend to develop more permanent damage. The lower limbs have a mechanical axis which runs from the hip joint to the center of your knee to your ankle joint. If this is altered in any way, usually to the inside, and which is where you see people with bent legs, they are then more predisposed through abnormal weight distribution to early arthritic changes. Similarly, somebody who has suffered a cartilage injury or a fracture may be more prone to developing arthritis. It has also been shown that people with a higher body mass index and those who have significantly higher weight are more prone to arthritic changes. There has also been implicated a certain disposition where families tend to have more amounts of arthritis. Osteoarthritis is also more prevalent in women at a younger age group, but after the age of 60 and 65, it is equally prevalent in men and women. What is significant to note is that as people grow older and have significant arthritis, they then lose their mobility, and studies from various parts of the world have shown a higher rate of hospitalization eventually in these patients. Also, they are known to have higher cardiorespiratory problems when you have arthritic joints and your mobility goes down. So, having seen the magnitude of the problem as well as how people present with it, the next question that one must ask is, does everybody require surgery? The answer is no. Most people can be managed early on with a walking aids, with medicines which could include simple painkillers, with correction of their footwear, and also with what we call now as nutraceuticals, which is a combination of various nutritional elements which help with arthritis. Only those who have significantly advanced arthritis where they don't respond to medication, as well as X-rays which reveal a severely degenerate joint, must undergo joint surgery. So, what are all these non-operative methods? Well, we commonly give anti-inflammatory medications such as non-steroidal medicines, which could include diclofenac, aceclofenac, or etoricoxib. Now, these could be short-acting and long-acting. However, the objective is not to give these for a period of a very long time, as these can cause problems both with acidity and renal issues. The other medication that we tend to commonly employ are nutraceuticals. These have increased in usage worldwide. Earlier on, we used to give a combination of glucosamine, chondroitin, MSM, now various S-adenosylmethionine, fish oil. A lot of these have been employed over the past few decades. What we have found is that not a single medicine but a combination works. More recent medication now employ more scientific methods where they give a combination. They tend to give collagen type 2, which is also a component of your normal joint, and we tend to give about 10 grams orally a day for a period of a few months. And the theory behind this is to strengthen your cartilage. They also employ anti-inflammatory medication such as curcuminoids as well as black pepper, which decrease joint inflammation. These medications also include certain other products such as sodium hyaluronate. The theory, these are all scientific combinations, and I have personal experience with usage of these, and they seem to act very well in our patients. However, these again must be given to people who are suffering from early to moderate arthritis, and those with severe arthritis, they may or may not work. What are the other things that we employ? Well, walking aids tend to reduce forces on the affected joint and are strongly recommended. We also tend to use braces. A lot of interest has also gone into joint injections, and these could include injections such as platelet-rich plasma or injections such as viscosupplementation such as hyaluronate. What we have found is that for people who are older, as with degenerate joints, viscosupplementation works very well. The theory behind this is that high molecular weight sodium hyaluronate, when injected into the knee, replaces what is normally a component of the knee. The normal knee fluid does contain sodium hyaluronate, and this acts by reducing the inflammatory markers in the knee like interleukins, which destroy the cartilage. Arthritic knees tend to reduce in sodium hyaluronate as well as have inflammatory markers, which is where you get a swelling in the knee, and these act to destroy the normal cartilage. So by injecting high molecular weight sodium hyaluronate, what we tend to do is we tend to reduce the breakdown of the cartilage. Arthritis per se is an irreversible process, but by giving a combination of nutraceuticals as well as sodium hyaluronate injections, we tend to reduce the progression of arthritis, and people are able to carry on successfully for a very long period of time. So we've been through what is arthritis and how we can manage it. The next question that a lot of people have in mind is who actually requires surgery? Well, certainly when you have advanced arthritis, surgery is required if you are not responding to non-operative methods. Also, those who develop arthritis at a younger age sometimes require joint preservation surgery. One of the challenges that we all face now in our practices is seeing younger and younger people with arthritis. It is this group of people in whom we employ joint preservation surgery. Joint preservation surgery can be in the form of an operation where if your legs are bored or knock-kneed, to cut the bone early on and straighten it, which is what is called as an osteotomy. So for people with various deformities, that is with bow legs, we cut the tibia and it's called as a high tibial osteotomy. For people who have knock knees, we straighten the bone out here, which is called as a distal femoral osteotomy. These are useful if the axis of the limb is altered. Equally, younger people with focal cartilage defects can have cartilage regeneration surgery. So this can be in the form where we look through the knee. Early on, we require a MRI, which tells us the picture inside the knee. And in our hospital, we have a 3 Tesla high resolution MRI, which also gives us a very accurate picture about the cartilage of the knee. We also have X-rays which go from the hip as well as through the knee to the ankle, what we call as long leg films, and these tell us the axis of the limb. If there is a focal cartilage defect, which is very small, we then look through a keyhole, what is called as an arthroscopy, and we carry out small drilling, what is called as a microfracture. This then opens up the marrow inside, which forms a clot, a blood clot, and that the cells in that are supposed to have reparative capacity. This is called as microfracture and works for small defects. For people with larger defects, we employ other methods of cartilage regeneration, which could be in the form of either taking your blood or bone marrow, centrifuging it, isolating mesenchymal cells which have reparative capacity, and then pasting it back on the defect. And we have had very good success with this. But all these work when the axis of the limb is well aligned. The other method of cartilage regeneration includes taking some cartilage from the non-weight bearing area and transporting it to the defect, which is called as OATS, as well as something called as autologous cartilage implantation, where cartilage is taken from the area of your knee, grown in a lab, and then this is brought back in a cultured suspension 6 weeks later and then transplanted back into your knee. So having seen what are the methods of joint preservation in younger individuals, in older people we tend to employ joint replacement. Joint replacement is one of the most successful operations in history. However, the satisfaction of patients is seen to be much higher when they have bone-on-bone arthritis and if they have employed all the other methods and these haven't worked. This can be in the form of a partial knee replacement or a total knee replacement. The knee has 3 compartments, a medial, a lateral and a patellofemoral. So if one compartment is worn and not the whole knee, partial knee replacement can be carried out, which is most often for the inside of the knee, called as a medial unicompartmental knee. Partial knee replacements make your knee feel more normal. They are done through an incision that is much smaller than a routine knee replacement and they promote higher degrees of flexion. The recovery period is also significantly shorter. However, the longevity of partial knee replacements well into the 2nd and 3rd decades is a little lesser than when compared to total knee replacements. Also, modern total knee replacements permit greater degrees of flexion, and we now routinely do our total knee replacements through a subvastus approach where we don't cut the muscle, as well as we have an accelerated recovery protocol with multimodal anesthesia, which enables our patients to walk within 2 hours of surgery. Our partial knee replacements are also very successful, but we are quite methodical in choosing only those patients who have pain on the inside of the knee and no significant deformity for partial knee replacements. Those who have knee arthritis involving other compartments, pain that is not well localized, as well as severe deformities, do better with total knee replacements. We also employed knee replacements which permit high flexion as well as early recovery. Modern knee replacements also make your knees feel more normal, which is where when you walk you have earlier recovery. By employing all these methods, our patients are actually able to very often squat on the floor as well as sit cross-legged. They can routinely carry out non-impact activities like cycling, activities such as golf, and can play recreational sports as long as there is no high impact involved. For those who require computer navigation of the knees, we perform knee replacements with computer navigation. The computer navigation of the knee is particularly useful for those who have significant deformities of the knee. For those who require revision knee replacements, we also perform revision knee replacements. Revision knees are something which are now happening more and more often, and these do have a degree of success when the revision is well studied. These could be for loosening or for infection. Normally, the success of knee replacements is it should last well into your 2nd and 3rd decade. So, in summary, osteoarthritis of the knee has become a common problem. For people suffering with knee pain, you must seek attention early. We tend to first diagnose the problem with X-rays and MRIs if necessary. Other methods to manage this include giving anti-inflammatories for a short period of time and giving nutraceuticals, giving walking aids and braces, as well as physiotherapy to strengthen the muscles. Again, not a single nutraceutical but a combination of nutraceuticals including collagen peptide, anti-inflammatories such as boswellia, as well as sodium hyaluronate work well. People who are suitable for joint injections, what is called viscosupplementation, are those with early arthritis, and these have benefited people greatly. And in my experience, people with early arthritis do significantly well with these injections. For those who have employed all these techniques, or for those who have significantly advanced arthritis, we can then tailor the treatment either in the form of joint preservation surgery or joint replacement where required. This could be in the form of a partial or a total knee, and people do very well with these operations.